Carbapenems are a powerful class of antibiotics with broad-spectrum activity, developed in response to the rising problem of bacterial resistance to penicillins and cephalosporins. The first carbapenem clinically available was imipenem, marketed in combination with cilastatin, a drug that protects imipenem from rapid enzymatic breakdown in the renal tubules. Although effective for multi-drug-resistant infections, imipenem cilastatin has notable drawbacks, including an increased risk of seizures, particularly at high doses and in patients with renal impairment. Meropenem was developed to retain a broad spectrum of activity, but with reduced neurotoxicity and improved stability in the kidneys. Compared to imipenem cilastatin, meropenem has less reliable gram-positive activity, but improved gram-negative activity. Meropenem is the carbapenem most used in pediatrics and is FDA approved in patients 3 months of age and older. Among the gram-positive organisms, meropenem has good activity against Streptococcus species and methicillin-susceptible Staphylococcus aureus, and moderate activity against Enterococcus species and coagulase-negative Staphylococci. Meropenem is not appropriate for empiric coverage of gram-positive organisms. In fact, Streptococcus coverage may be inferior to more narrow-spectrum beta-lactams like ampicillin, particularly for group B Streptococcus. Meropenem's gram-negative spectrum of activity includes Haemophilus influenzae, Neisseria meningitis, Proteus mirabilis, E. coli, and Klebsiella pneumoniae. Ampicillin sulbactam, piperacillin tazobactam, and third and fourth generation cephalosporins also have activity against these organisms. The difference is that meropenem has excellent activity against extended spectrum beta-lactamase producing strains of these organisms, while penicillins and cephalosporins are easily broken down and rendered ineffective by ESBL producing strains. Of note, the most common ESBL producers are E. coli and Klebsiella species. So if resistant strains of these organisms are suspected, meropenem is a good empiric option. Meropenem, like cefepime, is stable against hydrolysis by AMP-C beta-lactamase producing gram-negative organisms, including Citrobacter, Enterobacter, Serratia, Morganella, and Providencia species. However, meropenem's stability is more robust versus cefepime, and so it may be preferred when these organisms are highly suspected. Meropenem also has good activity against Acinetobacter and Pseudomonas species, which are intrinsically multi-drug resistant organisms. Coverage against these pathogens is more robust versus piperacillin tazobactam and cefepime, which are generally effective for Pseudomonas, but not for Acinetobacter. Meropenem's more reliable activity against these organisms is due to its improved stability to various beta-lactamases, high affinity for a range of penicillin-binding proteins, ability to penetrate through porin channels, and its reduced susceptibility to efflux pumps. Finally, meropenem has good activity against anaerobes, which are commonly covered in intra-abdominal infections. Coverage of gram-negative anaerobes like Bacteroides fragilis is comparable to piperacillin tazobactam and metronidazole. Ertapenem was developed a few years after meropenem and has the benefit of once-daily dosing. Ertapenem's spectrum is slightly more narrow than meropenem's, as it lacks activity against Enterococcus, Acinetobacter, and Pseudomonas species. Carbapenems should be used with caution, as their broad-spectrum activity increases the risk of antibiotic resistance and may compromise their effectiveness for future use. Carbapenem-resistant Enterobacteriaceae emerged in the early 2000s, and since then, antibiotic stewardship efforts have aimed to prevent further resistance by limiting meropenem to a last-line agent. Meropenem should be reserved for infants and children with multiple previous antibiotic courses or other risk factors for multi-drug resistant gram-negative organisms, and for those with confirmed resistant infections. In patients being managed empirically who fail to clinically improve on more narrow-spectrum antibiotics, you could consider escalating therapy to Meropenem, but remember that Meropenem will only significantly broaden gram-negative coverage. You may need to also consider adding MRSA coverage with another agent. Meropenem has good intra-abdominal, lung, kidney, and CNS penetration, so it can be used to treat a wide range of bacterial infections if needed. Like penicillins and cephalosporins, carbapenems bind to penicillin-binding proteins, disrupting bacterial cell wall synthesis. Adverse effects include seizures, thrombocytopenia, nephrotoxicity, hepatotoxicity, hypokalemia, vomiting, diarrhea, constipation, rash, and hyperbilirubinemia. Again, carbapenem use increases risk of future resistant infections and treatment failure. Carbapenem exposure also increases risk of fungal infection, especially in extremely preterm and very low birth weight neonates. Consider fluconazole prophylaxis in these neonates, or in any neonate with multiple risk factors for fungal infection. Thanks for watching. Please let me know in the comments what topic you'd like me to cover next.